All right. Thank you, everybody, for joining today's webinar. I'm Nicole Clement, a program specialist here at the National Rural Health Resource Center. Before I hand it over to Terry to introduce our topic and our speakers, I'm going to just put out there a few task announcements. So first of all, we would really like to encourage each state Flex program to think about the work that you've been doing for the past year or two and consider submitting a proposal for a breakout session at this summer's Flex Reverse site visit. Your peer Flex programs love to hear about the things happening in other states that have worked and what the lessons learned have been to get there. So we're accepting breakout proposals through March 11th. And just so you know, even if you don't submit one, we may very well be getting in touch with you to present anyways. So please take a minute to submit a breakout session proposal for the reverse site visit. And I'll paste the link in the chat to that proposal form. The Flex workshop, if you have new staff directly responsible for executing the duties of the Flex Award, they need to attend a Flex workshop within a year of their start date. The next workshop is being held virtually beginning on March 21st, and there are still a few spots open, but attendance is limited. Please submit a request to participate at the link that I'll paste in the chat as soon as I get done talking here. And then just a couple more events that we have coming up. The FY 2022 Flex Program Non-Competing Continuation Guidance webinar is going to be 2 p.m. Central on March 3rd. And then also we have rescheduled the TAF 90 webinar about health equity that is now being held on March 31st, also at 2 p.m. Central Time. So that's it for announcements. Terry, I'll turn it over to you.
Thank you, Nicole. The topic of today is Tele Palliative care and Telehealth Hospice. And I'm extremely pleased that we're focusing on this particular area, because if we look at our care coordination continuum, we start, perhaps with prevention and wellness, hopefully, emergency care, et cetera. But on the back end of that continuum is assistance in how we die. We believe this is very relevant for our Medicare Flex programs. It has a whole lot to do with completing that care coordination continuum. It has a whole lot to do with population health and ensuring that we have the services that are needed in rural America. And as I said, it's particularly important for me, at least, because both of my parents died in hospice. And I hope many of you have never had to experience the death of a loved one in that regard, but I can just tell you, it's an absolute gift to have hospice and palliative care services available for your family, because it's not just for people that are dying, but it's very much for the entire family as well. So what we have known in the past that our critical access hospitals have struggled to provide these services, partially because of the great distances. So in essence, if somebody's living 35 miles away from the hospital in Grand Marais, Minnesota, for example, it's so difficult to provide those services in the home. And obviously, some hospitals have set up hospice programs within their hospital, but telehealth now presents an option of bringing palliative care and hospice out to everyone, just about in rural America. So certainly the capacity is created if we can get past some of the broadband issues, et cetera. So I want to introduce our speakers for today. Dr. Eve Lynn Nelson is with the University of Kansas Medical Center. She's a psychologist. Her responsibilities include project implementation management, project management, coordination of evaluation teams, and the evaluation section. She also serves as behavioral pediatrics lead in the ECHO project. By the way, if you're not familiar with the ECHO project, do look into it. It's just an absolutely wonderful rural telehealth program. She oversees behavioral pediatric services with telemedicine, and she oversees the Department of Pediatric Residents, Psychology interns, psychology graduate students, et cetera. Dr. Nelson has worked with us several times before, and we're really grateful to her for being here. She's going to lead off. Sandy Coleman is the CEO Administrator of Hospice Services and Palliative Care of Northwest Kansas. And she joined hospice in October 1982. She served on leadership role in that leadership role since '84. Her area of Northwest Kansas has 16 counties, over 15,000 square miles, and I think what is the population of 60,000 people. So really, it's definitely a rural area here. So Sandy's got a vast background in actually running a hospice service and palliative care services. And then we have one of our own folks from the Office of Rural Health. Pat Justice is Executive Director of Rural Health at the Washington State Department of Health. She's been with Rural Health since 2014. She's led a team of 12 professionals, and prior to that position, Pat led the Department of Health Medical Home Collaboratives. So we've got a good array of speakers here. Dr. Nelson's going to go first, Sandy will follow, and then Pat will be our third speaker. If you do have questions, put them into the chat, and we'll try to find some time later in the webinar to, if you have some questions you want to ask personally. So, okay, Dr. Nelson, I'm going to turn it over to you.
Thank you, Terry and Nicole. Really appreciate this opportunity to talk telehealth with an area that touches each and every one of our lives. I really want to repeat what you said. We'd love to have your questions and comments throughout. So please do use that raise your hand function and typing in the chat, because we really want to tailor what we're talking about to your highest interest. We wanted to start off with a quote from one of the hospice nurses. We are available to families 24/7 and work on God's time. I think this really brings home that telehealth and technologies, they work the very best when it's complementing this overall mission. And I know with Hospice Services Inc. and Sandy and her whole team, it's really this mission driven focus. How can we help our neighbors and how can we deliver the very best care? That's really what you'll hear throughout our presentation, is that's when the technology is working its best. Started out, I think you've heard this with many of the telehealth speakers that you've had. Looking out my window today, it really looks like the picture on the far right, where we've got about a foot of snow on the ground. You can imagine as hospice and Hospice Services Inc. is covering this 15,000 square mile plus area, really facing barriers with weather, be it snow, sleet, or tornadoes here in Kansas. All those sets of things that can be a real barrier for teams and patients to be able to connect. So we think about accessibility, availability, just having few resources within that frontier area of our state, and also acceptability. What you'll also hear throughout is by leveraging the really trusted relationships that Hospice Service Inc. has with its communities, it's really helped also address concerns around stigma. I'm a psychologist by training, so part of that is also, really opening that front porch and being able to connect via technology around behavioral health, as well as the broader health and support that hospice provides. I'm going through this pretty fast because I want to give you an idea, a little bit of our history, but really get to the meat of what I think folks are going to find the most interesting is when we get to Sandy and she can give us some real life examples of how this looks day in, day out. But on the history side, Sandy and Dr. Doolittle were real visionaries with some of the telehealth. Starting back in 1998, they started Telehospice 1.0. It was really with our plain old telephone systems, the video phones. So the picture wasn't awesome, but the connection was. Even with the early technologies, it offered new opportunities for the hospice team to keep in touch and to join with the patients and families in their home. Fast forward 15 years, so more in 2015, we see the technologies better, faster, and cheaper. But what has retained over that time is how can we use the technology to meet a need that the hospice nurse and patient are seeing? How can we use it for the telecommunications and rapport building and support, as well as some of the assessment and treatment that we'll talk about in just a minute? Just a shout out, it's really a Hospice Services Inc. led program with the supports of University of Kansas Medical Center and the Masonic Cancer Alliance. I wanted to just give a overall slide. Again, folks, please do type in the chat because you all may have really deeper dives in looking at what is palliative care and what is hospice care. I really like this graphic because it's a reminder that it's a continuum, that you know, we are looking at that trade-off as we are coping with illness between curative focus and palliative focus. I like the dotted line that kind of walks us through that because it's not a yes, no. Sometimes maybe leaning into the curative focus with our healthcare teams, and it's sometimes we may be leaning into the palliative focus with comfort and support treatments. And then as we go through that path, we see hospice and hospice services within that last 6 months of life. And then also Sandy and her team really focus on that continued support around bereavement and helps for the family even after and beyond death. This is a kind of a practical slide that says that same thing, that there are many factors with palliative services and hospice services that are in common. That center circle really is speaking to the idea around holistic care, comfort care, reducing stress, offering complex symptom relief related to serious and life-limiting illness, and then also addressing physical and psychosocial relief. On the left side, you see specific to palliative services. And again, we saw those services kind of as you saw that dotted line where sometimes it's more or less of these services. They're paid by insurance or by self. Palliative services is kind of that bigger umbrella that may occur at any stage of illness and disease. The palliative services can occur concurrent with curative treatments. Oftentimes focusing in on some of the pain management, the symptom relief, and coping with stress. And the palliative services typically happens in the hospital setting. On the right-hand side, we see specific to hospice services paid by Medicare, Medicaid, and other insurance. When the prognosis is 6 months or less, it's at a time where you're really focused in more on the palliative and hospice care and not the curative treatment. And then really reaching out to wherever the patient calls home. This is a little bit more details, more for you to have in your back pocket as you're thinking about options with your programs and potentially looking at tele palliative care and telehospice. again, just more as a background, one reason that telehospice and tele palliative care have really caught hold in Hospice Services Inc. and in our state of Kansas is because of the frontier nature of many of our communities. I know when we meet with Sandy's team, she's always really emphasizing, you know, in our frontier communities across 2 time zones, how do we really take care of our neighbors, and how can the technology help us achieve that, especially in the frontier settings that we're serving. This just gives you a visual of where Hospice Services Inc. is located in the northwest corner of our state. You see, we have one academic health center in our state. So really about 9 or 10 hours of travel between that academic medical center and the region served, as well as the excellent support and treatment options that we see with our critical access hospitals throughout the state. When we think about models of telehealth in hospice and palliative care settings, this is just kind of a slide to get all of us thinking about the range of services that can be offered. With the Hospice Services Inc. and Telehospice, we've really leaned into telecare. So looking at when can we really lean into the telecommunication function of the technology, really to extend communication and caring. So when does a picture give us more is kind of that idea. When can it help us connect and develop that trusted relationship with our patients and their families? It also then offers access to services. This may be increased access to team members. So it may be the hospice nurse at the home with the patient who is then able to connect back to another care team provider in a different county or counties away to help with assessment, intervention, and support. This may include things like access to the medical director, access to the social worker, access to the chaplain, or access peer-to-peer as nurse-to-nurse support as well. And this is across assessment, intervention, and support. Telehospice and telepalliative care also open the door to using the technology to connect with specialists and multidisciplinary teams. So some examples of that are connecting around pain management, connecting around wound assessment. We've had some connections around pediatric palliative care. So really using the technology to open the door to some of those specialist services. The technologies also open the door to access to families, to some of the broader supports, support groups, also bereavement supports, and really extending what's on site to have that broader reach and be able to be shared with families across the region. With the teleclinical services that we just talked about, hand in hand with that has come interest in how can we use the same technology to deliver educational services, really just like we're doing today. So how can we use the Zoom and those technologies to share best practices around palliative care and hospice? Some of that has come through opportunities with telementoring and Project Echo that Terry mentioned, and we're really excited about those models. One innovative thing that Dr. Doolittle and Sandy led was extending our palliative care fellows rounds. So those are rounds that, you know, they happen weekly. So really looking at adding the technology so more of our folks across the state could participate and learn and share in those rounds. And then finally, remote patient monitoring is being used more and more in telehospice and telepalliative care. So monitoring the vital signs, monitoring pain, all those sorts of things can be very useful as we're looking at serving our hospice and palliative care patients. thinking about some of the opportunities and barriers with telehospice and telepalliative care, I'm going to go to that in just 1 minute. I want to point out the technology that you see on this slide. So again, we started with those video phones, and then we moved some to the really big, expensive room-based technologies. But now we're really able to use some pretty cost-effective, secure technologies with our iPads, with other smart devices, and with both patients and families be able to utilize that technology that often folks are now Skyping with their grandkids, or they have some experience with some of those technologies. We're, of course, using a little bit more secure technology with the professional version of Zoom, but the idea is the technology is accessible and has really extended some of the reach of these services. So I'm going to start on the barrier side, and then we'll touch base on the opportunities. There still, of course, are barriers around telehospice and telepalliative care. First off is just some fears with anything new in any service. It makes a ton of sense for folks to be cautious and to think, with this new access, is there anything we're losing? So I think this one was important for us to think through. The Hospice Services Inc. has been very thoughtful about making sure the technology is used to maintain relationship and extend relationship, making sure the rapport components are there, and also really emphasizing this is not to replace any of the excellent nurses and caregivers. It's really to complement and to extend that reach. There are barriers around just having availability to multidisciplinary teams. We talked about the pain management team. You know, still, even with the technology, it's challenging to find availability. There's reimbursement challenges. Oftentimes, this is a bit of just unknowns and not having some question marks about the reimbursement environment. There's barriers around requirements for in-person evaluations. There's barriers around technology use and comfort with technology. Of course, with some of the pandemic use and tipping point with that, there's been more use of the technology and familiarity, both on the provider and the patient side. There's challenges around staff shortages and turnover. With telehospice, it's really hard to introduce something new if the organization is experiencing a time with staff shortages or turnover. That can be a challenge to get traction with some newer interventions such as telehospice. There's challenges around late referrals to hospice. The very large geographic areas covered, those are both barriers and opportunities, of course. And then right now, I know we're really experiencing some of that, just staffs being fatigued and just really tired, and experience some of the resilience fatigue and beleaguerment. Sometimes then it's harder to introduce some of the newer interventions like we're talking about. With that, of course, also comes opportunities. I think the overall take home from barriers and opportunities is there are solutions. It just takes some thinking through and testing things out and seeing where is technology the right fit to address some of the barriers. Some of the opportunities are the ability to continue services. We've talked a little bit about the telecommunications opportunities and using the technology for relationship and trust. Sandy has some just wonderful examples of that we'll hear in a moment. There's opportunities to use the telehealth as a staff extender, opportunities to improve access to care, really looking at opportunities. When does telehospice and telepalliative care fit up with some of the community needs that folks are expressing? it opens the door to really think about what's the range of palliative services offered. I'll say we've done teleautism to telewound care, so almost A to Z. About everything you can think of can be tried via telehealth. So just really thinking creatively about some of those palliative services and how that could look with technology. There's both challenges and opportunity. We see in our Northwest region of the state an aging population, as many other rural areas may be experiencing. So that is new opportunities to think, how can these services help meet that need of a growing population? And then, of course, there's new technologies on the horizon, some of that with remote patient monitoring, new things around wearables, and all that is awesome. Just thinking through, where does it meet a need that we're seeing, and how can it help complement our best care? This is a reassurance slide. This was actually pretty early on in Tele Hospice 2.0, but just the idea that there are some costs with technology, but what we see is the costs that are saved, not just around the patient visits, but also the time and the cost saved around travel for things like interdisciplinary team meetings and administrative meetings. We really see a total savings that has a significant impact. Sandy can speak to this better than I, but I know I've heard her say that, you know, two FTEs are devoted to travel and covering that wide area. And because the technology can help decrease some of those costs, it opens the door for some other services. So with that, I'll hand the slides to Sandy. Sandy, you let me know, should I advance the slides for you, or do you prefer to bring up the slides?
Hi, Dr. Nilsson, would you advance them? Thank you so much for sharing for that information. This is an important slide to me that I do want to be sure everyone is aware of. When referrals, it's a little bit outside of some of this, but I think it's important information. Early on, when hospice was created under Medicare, it was a Part A waiver. And again, critical access hospital, rural health clinics, the rural health clinics, federally qualified health centers were also created kind of as a waiver program. What no one really understood from the very beginning is the one precluded the other one from getting paid. So if the person was on hospice and they were seen at the rural health clinic or the federally qualified health center, their care was denied. The clinic could not bill for that. We spent a great deal of years, a lot of time, and sought a lot of partners, and that glitch is repaired. It's a similar glitch occurred with skilled nursing visits or skilled nursing facilities, but they caught that sooner because it was a larger volume. But they finally caught this. It's being basically addressed in kind of a similar way. So beginning last month, providers in rural health clinics and federally qualified health clinics can seek reimbursement and be paid. Next slide. Next slide, please. While Dr. Nilsson's working on that, the next slide is really a list of stories. And I want to share, as we look at telehospice, tele palliative care, I have a variety of stories, and I want to share those. I think one of the things that I want to start with is you will see Anna listed as the first story, and Nicole is going to attach that video on the website. Anna was a grandmother that we cared for, and I missed a slide, I'm sorry. Okay,
I'm
we'll go there.
sorry it paused, Sandy, so I
We're
just
good.
restarted it. Thank you.
We're good. So Anna was one of the early ones we placed an iPad with. And one of the things I'm going to talk about is I think this has the professional use. And I think we need to talk about that because that is absolutely vital to continued healthcare in rural and frontier areas, that we utilize that we make it work. But I think there's also a personal and again, behavioral isolation, loneliness. And I was so pleased with this opportunity and the insight and vision of KU to realize that quality was as important as cost, that both pieces are vital. Anna was a grandmother. She did have an iPad. Again, she'll tell you a story, and I think it's important to know because one of the questions always asked is, how do the elderly do with the technology? Anna will tell you in the video, if she can learn it, she can teach anybody to use it. She used it most evenings to converse with her grandchildren in another state. Anna also used it one night. She was anxious and called the nurse and visited with the nurse, could see the nurse could see her, kind of talk through some of her anxiety, and she said she was ready to go to sleep. She didn't want to leave it on with the nurse because she thought then if she woke up, she could just talk to the nurse right away, but we agreed that she could just call back. Again, throughout this, you're going to see both personal and professional, and I think it's really important to know that there are both uses. Some of these are very personal. We were taking care of a gentleman in Goodland. He was a veteran. And if you know much about all of our rural areas, most of the time you drive more than the time you spend flying to get home. And his son lived in the DC area, and there was a significant change in his condition. We did contact the son. We were able, with the nurse visiting in the home, to dial in the son and his family. The son made arrangements, was going to fly out the next morning and then rent a car and drive. They really felt like the family would drive out themselves. However, that evening, the family had the opportunity to say goodbye by audio visual. Again, I think a personal story. The son did fly in the morning, and his father died about 30 minutes after he arrived. One of the things that I think we all know as rural is that many of a portion of our population are elderly, and adult children have moved away, and they're absolutely fearful what mom and dad are going to sign without knowing, and they can't always be there. They have commitments. One of the things that, again, we've used is involving adult children in the admission, the referral, the admission process, in the care. We had a mother in a nursing facility, and her children, all but one, lived out of state. They were a very close family. So we kind of did some visiting and care planned with the family that when the nurse made a visit, the nurse would join Zoom, and the children had that Zoom link so they could join if they wanted to be part of the care. So it was really interesting because almost every visit, at least one joined. Again, not everybody can get home in time. One of the daughters was not able to make it home, but was able to say goodbye via audio visual. And I think, again, some are so comfortable with telephone, but I think the visual adds so much to our communication. It is so very important to be able to see. We talk a lot, email, text. We don't always understand the tone. We don't always realize kind of the facial expression. We don't always know what they're trying to convey. But with the audio visual, it's amazing how much better you can communicate. We do veteran pinnings, honoring our veterans. We often invite families to join us for that. So again, as opposed to someone out of state having to take a couple days off, they can take a late lunch and join via Zoom for that. On the first slide, you did see our roads. Again, many of us have challenges with weather in a variety of ways. And I don't always really think of that till I visited with somebody from Alaska, and their challenges seem much more overwhelming than mine. But again, the ability to use the audio visual to check us to feel better, for the family to feel better. One of the professional uses that I think we all need to look at is in rural areas, people drive a long way for care, for a specialist. As Dr. Nilsson shared, for someone from our area to go to KU, which is oftentimes the choice, you're looking at an 8-hour drive for some. And if you're ill, that's really, that's difficult on most of us healthy, let alone someone who's ill. So I think, again, the advantage that telehealth brought, again, I'm so thankful for this project with the University of Kansas, because we were prepared for some of this when the pandemic hit. And so for us, it was much more of a comfort level. But again, I think a lot of advances were done. Again, here are some things. One of our patients was able to join her cousin's funeral in another state via Zoom. Again, here's a little bit more about Anna, who Zoomed at night. A grandmother participated in her granddaughter's wedding. So again, some very personal. Someone shared just that they're doing a lot of research on the health effects of loneliness. And I think, again, as we're developing technology and we learn to use it better, I just think that's an across-the-board benefit. Our wound care nurse lives at one side of our service area. So we've been very, very appreciative that the technology is so clear that we can get permission. We can Zoom with our nurse in the home, the wound care nurse on the other end, but can look at that wound and can really help us. We've connected with a provider for a person at home. Many of our people are not able to get back out to the clinic. And, one more visit or one more time to say goodbye. We also do use it for our interdisciplinary team meeting. We have staff scattered across our service area. Dr. Nilsson was right. On any given month, we have roughly 2 FTEs in travel. If for our staff to all gather together with time and mileage and travel, it's about $2,500. So it's not something we can do often, but telecommunications has allowed us to connect. And I think, Dr. Nilsson, if you might back up one slide, please. I skipped right by this. Again, I think similar things to the others. So, and please, if you have questions, join in. Now, Dr. Nilsson, if you might go 2 slides forward. This is really important to me because I will tell you, one of the things I continue to learn is some of us do so well utilizing telecommunications. Dr. Doolittle, who is credited on the end of the slide, I attended a webinar that he did, and all of us in the classroom would have sworn he was in the room with us. He was there on the camera, he was visiting with us, but he just had the ability that it was very, very personal. The next person who spoke was a nurse, and you can tell her familiarity was not yet developed. So I will tell you that that's probably a lesson we are still learning, is how do we feel comfortable with comfortable with the technology. Our staff have got to be comfortable before we can teach someone else, before we can encourage the patient to do it. Our staff want to be sure they know what they're doing so they can help the family out. We need to keep up with education. Again, we realize making mistakes. One of the things that was just, we used a different technology. And so for many of our staff, it was adjusting to a very different technology format. So again, I think finding that. I do think, again, the pandemic advanced telecommunication so quickly. I think years ahead of where we thought we'd be at this time. And so I think, again, many people, some question was, will the elderly use it? I will tell you, I think that wall is coming down, because for many of the people in our area, if they want to communicate with grandchildren, they've already learned to FaceTime or Skype, because the grandchildren, it's difficult to get away from commitment. It's difficult to attend events for the people here to attend events. So again, I think the wall with technology is coming down, and everybody's learning. And as you look at Anna's video, if she can learn it, she can teach any of us to learn it. Again, I think equipment, the workflow, I think really kind of figuring out what works, how does it work, how do we keep supporting our staff, how do we keep up with, advances. One of the things as technology, we have to do an update, and then we all have to kind of adjust to what all the update change. So again, that's out there. But I do think, I think we need to keep working at that, because again, I think as we are all of the workers, the shortages, I think we're going to have to figure a way out to extend our workers. And I think we have a chat here. Someone worked for hospice. And again, yes, telehealth is amazing for the future. Any questions on this? I kind of slipped through. And Evelyn, I'll let you kind of finish with the last slide.
Wonderful, Sandy. It's so much to take in. Every time I hear you talk, there's a new use of the technology. So really appreciate hearing all you had to share. I'll just share that our telehealth resource centers are HRSA-funded entities. If you're excited about starting telehealth or considering some of the technical assistance in starting or extending telehealth to telehospice and palliative care, just sharing that we're resources. I'm at the Heartland Telehealth Resource Center and would be glad to talk with anyone and also get folks connected to their regional telehealth resource center if it would be useful. Just a big thank you again. Thank you to Terry and Nicole and to Sandy. And also Alana. Alana was really our behind the scenes person who helped us with these slides. And then to our broader team, of course, our patients, families, partners, funders, and communities. So thanks so much.
All right, making sure I have everything unmuted there. So you may wonder, I didn't put in my bio note, like, why me on this? Maybe a few of you know that at the Washington State Office of Rural Health, we started planning for palliative care in rural communities in late 2016, and we've been working with rural communities on this integration since we brought in our first cohort in 2017 and a second cohort in 2020, and I'm the lead of that work. What I want to talk to you about is first, why did we start anyway? What our model is, what to consider when starting a program in your state, and lessons learned. Although we're doing several domains of strategies, I will focus on the telehealth and telemedicine in congruence with today's topic. So this is some of the data that got me sort of fired up. I should give the background that in 2005, I was working for an acute care hospital, and one of the first board certified palliative care physicians in the state wanted to start a service there and asked me to do focus groups with physicians. He wanted to understand what the opposition would be. So that got me very interested. But I went to the Center for the Advancement of Palliative Care, or CAPC as it's called, and they had this data about the tripling of the program in hospitals 50 or more beds. And then they made the point that only 17% of rural hospitals with 50 or more beds report. They didn't even talk about critical access hospitals in their data. So I can only guess what percentage we're at. So we in the advisory team began talking about the ROI, the business case, but more importantly, the ROH, which one of the members termed as the return on humanity. And I just want to talk about that for just a minute. You know, in these communities, everybody wants people who are suffering to have some kind of relief. But the providers, clinical teams, patients, and families may cling to curative treatments because it's what they know. No one wants to say there's nothing more we can do for you, but sadly, some patients still hear that. So palliative care that's not hospice is really low in awareness, and it's often confused or thought to be giving up. But what we talk about is that it's about living well with illness. And this was the bottom line motivator. At a time of great stress, rural residents deserve to be with the people they love in the places they love. So our objectives were to assist the rural health systems and their communities to integrate palliative care in multiple settings, not just hospital-based, to better serve patients with serious illness. We wanted decreased transfers to urban tertiary services. We wanted to move upstream to serve patients with serious illness earlier in their experience of illness, and perennially develop funding models for sustainable services. So this is a model that we vetted in our original advisory team, and I'm not going to talk in detail about each piece of it. I will just briefly talk that community engagement, Stratus Health gave us a great bump with that in terms of model where you go in and do asset and gap analysis with a community team and then have them develop an action plan. We focused a lot on the clinical skills, particularly the communication skills that are required to have the conversations, and the culture change. It's a different way of looking at care. And we began in 2017 with telehealth case consults, as well later developing the direct-to-patient clinical medicine. I'll let you know that we didn't choose to go with Project Echo. I love Project Echo, Terry, but the thing for us was we didn't want to have to worry about fidelity to the model. I've since heard that there's some flexibility, but the programs that we were familiar with were very didactic. You know, there'd be a case presented and then a didactic session, and we wanted our panelists to be in active dialogue with the rural team and to show deep respect for the rural team's knowledge and skills, because they've been taking care of patients with serious illness before we came along. So that's why we did our own kind of look-alike, but we don't do didactics in that hour. We do use learning moments for sure. So I'm going to talk about the funding. You see, I made in-kind really large. When I started this, I pulled a few of my staff in and said, I promise not to make you work so hard you want to, you know, throw up or die. I hope that happened. And we're just going to start with what we have and figure it out from there. And I would advise you not to wait, you know, for concrete funding, to start shaping the work, to start having conversations. We've used flex funds, we've used SOAR funds, and we've even funded some education with PCO carry forward, primary care office. We did participate in a 3-state project with North Dakota and Wisconsin with Stratus Health. They were able to get some grant money and pass it through to us, and Alana and others were part of that evaluation. One of our state Medicaid managed care organizations gave us a bump, and then we're right now working with the Cambia Health Foundation. So it's leveraging funds, and I'm still seeking more funding. But we do have a sustainability plan. So I want to talk a little bit about how it can really look different in rural. First of all, there's a wide variation in structure and focus. We're not doing these out of hospice agencies for the most part. Out of our, say, 13 sites, we have one home health and hospice agency running a program. The rest are in primary care clinics, home nursing visits, inpatient, and one of them, it's an RHC where the nurse goes to the home and the provider gets on telehealth, and then we are seeing more and more of these blended visits. To get the whole interdisciplinary team together, we don't just have that in the way that a hospice agency might. So it's often multi-organization. We have one example where the critical access hospital owns the RHC that is really the corner of this program. They didn't have pharmacist capacity. And so there's a retail pharmacist in this town that has really stepped up and does all the med packs for their patients. You know this one. There's really dynamic issues of capacity to manage when workforce fluctuates. And when you're trying to do a fledgling service, that's particularly critical. I think the Frontier County map misrepresents us just a little bit. It depends on the definition of frontier, but we have more frontier in our eastern part of the state and really rural, let's call it. And I just want to give the example that one of our sites for this work is frontier, and it's larger than Maryland, Rhode Island, and Delaware combined, just this one county. There are 10 organizations on that team, and they kind of work at like zone defense, where depending on where the patient is, who responds. We have been using telehealth from the beginning, but it's really like everyone else, we see more and more ways to do that. So the original model has been mostly true. What we're trying to do are build skills and services in the rural community as sort of primary palliative care. And if you think about in other parts of medicine, your primary care physician can deal with a lot. Well, if we build these skills in the clinicians in the rural communities, they can deal with a lot of these cases. We use case consultation as the clinical complexity goes up. And then finally, we envisioned that those that needed true tertiary specialists would be direct telemedicine. However, it's not quite turned out that way, and I'll talk about that in lessons learned. You know, the best diagrams meet reality sometimes. So lessons learned, first of all, serious illness communication skills create confidence. We had one site that had been talking about palliative care for quite some time. And it wasn't until we did a day-long focus on communication skills, how to do a goals of care conversation, how to respond to conversations where you're talking about sensitive topics and doing that with skill. That was when they decided they could start seeing patients, because that was the core of what they needed to figure it out. They had a lot of resources around symptom management, and they could definitely use consultants with that, but it was how to talk that really held them back. But it is a big confidence booster. We, on the very front end, collaborated with all the hospice and home health agencies in the communities we were touching. We wanted them to make sure that we weren't trying to supplant anything they were doing. We wanted them at the table, and I think that we have really great relationships with them. So one of the heartaches in terms of lessons learned is that we use a standardized screening tool to screen patients in with serious illness, and we believe it could be started at the time of diagnosis of certain serious illnesses where the trajectory is pretty certain. But once people started using that tool, they began to see how many people could use the service and immediately started feeling kind of sad because the demand outstripped their capacity. So I prescribe that now. It's an old psych skill where you prescribe the symptom. And so I just warn people that's going to happen. And still, to maintain, when you start something like this, you need to start small, very small. See a few patients, see how that goes. And, you know, it's continuous improvement and doing improvement cycles from there. So one of the hard lessons, I recruited a critical access hospital that has been an early adopter in everything. And they must have cycled through, I don't know, 12 or 13 people as the lead for this work. And they never really got off the dime. We took a special 4-hour training right to them, et cetera. And so my lesson out of that is early adopters might be the people who have too many top priorities for transformation. They had a bunch of stuff they were working on, and we didn't have a passionate champion there. We had a sort of lukewarm champion, and the CEO had agreed to it, but I don't know that he was really giving expectations to that champion. Disruption from leadership turnover can jeopardize or stall fledgling services. In one case, we were really working well with a rural hospital, and this was a 50-bed or less, which we have a few. And the CNO was like very passionate about it. Well, when she left, the new CNO came in and said, I want you out of that. And our team lead actually ended up leaving the organization to go work for hospice because she didn't want to be in a place that wouldn't support this work. Our telehealth case consults are of large value to our cohort teams. I believe they have become, every panelist tells me, virtually every, I mean that, that it is the highlight of their month. When we first started, we were doing twice a month, but that's a lot to cycle in terms of getting cases prepared, et cetera. So we do it once a month, and there's just wonderful relationships built there. Our panelists include all the disciplines. So we have physicians, we have nurse, we have social workers, we have 3 chaplains that rotate in. And one of the social workers that we have is a behavioral health. She's a PhD social worker with palliative care and behavioral health training. So she's a gem. So clinical telemedicine, my vision was they would feel out of the step and they would be contacting, you know, a board certified physician and his team to get a consult or to directly talk to the patient rather. What happened is we built their confidence with primary care. They are using direct telemedicine to serve the patients in their areas. They feel like the case consult gives them what they need. And as I mentioned, at least 2, if not 3 of our areas are using that blended model where somebody goes in the home and other disciplines are back at the ranch, and they conduct the visit that way. So here's my thoughts about getting started in your own state office of rural health. First step is to do an environmental scan statewide and really look at what's happening. It was interesting in our 3-state project because when Wisconsin did their scan, they found a whole bunch of palliative care programs that they really didn't know about. Not so for North Dakota and Washington. We brought together an advisory team and we put palliative care experts, rural health leaders, and telehealth experts to help us shape our model. We also suggest medical schools and nursing programs. The more we can hook in education programs and have them supporting this and see it as a training opportunity, the better. So we built that model, and you'll have your own vision of what your model would be and what it's going to contain. But what you really need are local champions to bring together a community team to do that asset and gap analysis and develop an action plan. And when I mean community team, the healthcare organization is the lead. They gather. We give them a suggested list of participants, and they include things like local pastors, EMS, adult family homes, pharmacists, just about any part of the social service or health spectrum that could touch a patient with a serious illness. And it has been truly wonderful. One of our newer communities has absolutely taken off, and their community team is large and robust, and the community owns it with the critical access hospital in their clinic. And that's the ideal. The other ideal, we think, is that those community members are ambassadors of education, because one of the goals that I didn't include there was that eventually we want patients, when they're diagnosed with a serious illness, to say, I want that. You know, I want palliative care. Please tell me how I can get it. We ran this as not as a full breakthrough collaborative, which I did in medical homes, but we run it as a learning action network. And the quality improvement organizations, I think, were early innovators with that model. So we really think that peer-to-peer learning is huge. And we actually have designated our cohort 1 leads. Oh my goodness, I'm almost over time. I am over time. I'm going to wrap this up real quick. To really mentor that other folks. I'm going to say take the long view, because this work is not quick, and incremental progress is good. And then I'll stop there. What I have after this are some resources for you. How to order our roadmap, which is one of our community pieces. And then I've got some links for you. And with that, I'll turn it back to Nicole and Terry.
Thanks, everyone. I've really appreciated all 3 of the presentations. And again, as Pat's suggesting, it takes work, but I can assure you, just as one of our folks indicated in the chat, that it's worthwhile work. And if I can say it's God's work in that regard. I love that opening quote. So we have a post poll up for you to fill out, if you will, just a couple of questions here. And again, thank you so much for our speakers, and thank you all for participating.